Hello, my name is Robert Giugliano, and I'm the editor-in-chief of the new Anticoagulation Management Clinical Community, which is available on CardioSource. Today, I'm talking with Dr. Jeffrey Weitz from McMaster University in Ontario, Canada, on the topic of novel anticoagulants. Welcome, Dr. Weitz.
Thanks. Good to be here.
So I wondered if we could start today by talking about the traditional oral anticoagulants that have been available, and if you could give us your perspective from Canada on the limitations, challenges of the existing anticoagulants. Then we'll move on to the novel agents.
Sure. Well, as you know very well, for the last 60-odd years, the only oral anticoagulants that we've had for long-term management of patients have been the vitamin K antagonists such as warfarin. And although these agents are effective, they've got numerous limitations. They require variable dosing. The vitamin K content of the diet can affect the levels. There are multiple drug-drug interactions. There are common genetic polymorphisms that affect dosing. And because of these variabilities, we have to monitor them using the international normalized ratio, and we have to titrate the dose to ensure that the INR is in the therapeutic range. And this is burdensome for patients and for clinicians. And with all of these limitations, it contributes, I think, to the systemic underuse of warfarin for stroke prevention in patients with atrial fibrillation. And we also have data from the community and even from our own clinics that even when patients are put on warfarin, their INR is often outside of the therapeutic range, which means that we're either undertreating them or we're overtreating them. And this is not good for our patients.
Great, thanks. Tell us a little bit about your perspective on the novel oral agents and what's been the early read, if you will, from Canada.
Well, sure. The new oral anticoagulants have been available now since around 2009, 2010, and we've had tremendous uptake. So let me just tell you what's licensed in Canada for which indications. We have dabigatran, rivaroxaban, and apixaban, all licensed for venous thromboembolism prevention in patients undergoing major orthopedic surgery, elective hip or knee replacement surgery, and for stroke prevention in patients with atrial fibrillation. And we have rivaroxaban licensed for treatment of patients with acute deep vein thrombosis and or pulmonary embolism. For the prophylaxis indication in orthopedic surgery, rivaroxaban is the drug that is being used most widely in Canada, and it's estimated that in the orthopedic arena, it's probably got 65% of the market share for prophylaxis after hip or knee replacement surgery. Why is that? It's reimbursed, and it's once a day, and it's simple. For atrial fibrillation, apixaban is the newest kid on the block. We just starting to get some traction with apixaban. Dabigatran's been around the longest, and then that was followed by rivaroxaban. It's estimated that in Canada, that at least a third of our patients with atrial fibrillation are now on a new oral anticoagulant as opposed to warfarin. We also see the same phenomena that's seen in the United States and elsewhere, that we have sort of a cadre of patients on warfarin where warfarin is entrenched and there hasn't been a lot of switches. But what we're seeing is with the patients with new onset of atrial fibrillation, the new oral anticoagulants are taking a large percentage of the market share, and rivaroxaban has had quite a bit of uptake, and in some provinces, rivaroxaban has overtaken dabigatran now, and apixaban is just starting to find its niche. And in the venous thromboembolism treatment arena, we don't yet have reimbursement for the drug for that indication, but nonetheless, some patients are willing to pay out of pocket, others have drug plans, and the introduction of an all-oral therapy for treatment of patients with acute venous thromboembolism has really streamlined transition of care to get patients from the clinic home or from the hospital home. And it's also simplified the management of patients who have erratic INR control with warfarin. Now we have options for them. So that's where we are right now with the new oral anticoagulants in Canada.
What do you think about the future? If you could just tell us briefly. You already have several options available in Canada and seem to be, on a global scale, one of the early adopters there. Where do you see the field in 5 to 10 years? What do you think are the major challenges for the new agents?
Well, I think that within the next 5 years, we're going to get more effectiveness data to look at the effectiveness of the new oral anticoagulants in the real world to determine whether unmonitored therapy really is both effective and safer than warfarin. We still have a few challenges that I think will be overcome in the next few years. One is how do we monitor the new oral anticoagulants? I'm not talking about monitoring in terms of finding a drug level and adjusting the dose accordingly, but what do we do when we need to know the level of anticoagulation, say in a person who needs to go to surgery or needs an urgent intervention? How do we know whether the anticoagulant's gone? Or in a patient on one of the new agents who comes in with an ischemic stroke, how do we know whether it's safe to give thrombolytic therapy? So those sorts of things need to get sorted out, and I think with some more experience, that will get sorted out. The other thing is we don't have specific antidotes for the new agents, but an antidote for dabigatran and a universal antidote for the oral factor Xa inhibitor. Those are under development, and I would think that within the next few years we'd have those on board. I think, though, that the major challenge still will be there are going to be groups of patients where the new agents are not going to be appropriate. Those might be the patients with severe renal failure because all of the new agents are cleared through the kidneys. And the other thing that's become clear is that patients with mechanical heart valves, patients with artificial devices, where there might be locally on the surface of the device, there might be the generation of factor Xa or the generation of thrombin in concentrations that exceed those of the specific inhibitor. In those situations, we might not get away with use of the new agents, and we're going to be stuck with having to use warfarin for long-term prevention.
Well, that was really great. Thank you so much, Dr. Weitz, for your insights regarding the novel anticoagulants. And I want to invite you and the audience to visit the community frequently for ongoing information about anticoagulation management. This is Robert Giugliano for the CardioSource Clinical Community on Anticoagulation Management.